I am going to introduce Ron Jackson. Ron is an affiliate professor at the UW School of Social Work, where he has taught graduate courses in the assessment and treatment of persons with substance use disorders for about 30 years. And for 33 years, he was executive director of Evergreen Treatment Services, of which I'm a proud alum. As a social work student, he has served as a trainer and consultant on SUD issues for a variety of local, state, and federal organizations, including the Northwest Addiction Technology Transfer Center, for many decades. And most importantly, Ron questions everything and makes you question everything, and you should. You shouldn't believe any of this necessarily. You should question it and test it and argue about it, please. Whether it is crack babies, whether it is heroin babies, whether it is meth babies, whatever these things are that people tell you about, whether it is addicted babies. I'm picking on babies for a minute, but that's just one of my favorite misstatements. Ron will always push you on that, and I really appreciate it. And I think it's part of what pushed me into actually doing research is when I was telling him about, don't you know how bad crack is for babies? He's like, really? Show me that research. And about a month later, I was pretty exhausted, and I had to admit that he won. Anyway, with all of that, I'm introducing my friend and mentor, Ron Jackson, to moderate this panel.
Most importantly, he's a proud grandpa, but that's... So it's my great pleasure to introduce Dr. Susan Ferguson, who's our first speaker. She's going to talk about the immediate and long-term physiological actions and consequences of methamphetamine use, as you can probably see. So she's currently the associate professor at the Department of Psychiatry at UW and runs the research program investigating the neural basis of opioid and psychostimulant addiction. She also serves as the faculty liaison to the Office of Teaching, Education, and Research at Seattle Children's Research Institute. She's a graduate of the University of Michigan, Ann Arbor, with a BS in biopsychology and cognitive sciences and a PhD in neuroscience, and received her postdoctoral training from the UW. I'm a graduate of Vanderbilt University, and so Vanderbilt just beat Michigan in the College Baseball World Series. Just saying.
Yeah. They hadn't gotten there since the 60s, so.
Yeah.
We'll take that, I guess.
When you come from Vanderbilt, celebrating something like this is a once-in-a-lifetime experience. Right. They're the team in the SEC that Alabama always likes to schedule first thing out of the box. Anyway, most importantly, Dr. Ferguson is taking over on Monday as the new director of the Alcohol and Drug Abuse Institute. So please welcome Dr. Ferguson.
Thank you so much for that. And yes, I'm very excited to be taking over as director, and I'm certainly already humbled to be here among all of you. As a basic scientist, it can be somewhat, it's both amazing to hear all of the sort of boots on the ground kind of work and a little daunting from my perspective. But today I'm going to talk to you to really set our conversation for the session about potential treatments, particularly pharmacological treatments of methamphetamine addiction. So I'm going to talk to you about the pharmacology of meth. And so what do I mean by that? This is how is meth working in the brain to activate different circuits and to lead to addiction. Okay, so in order to talk about methamphetamine, you need to talk about dopamine. So dopamine is one of the major neurotransmitters in the brain. This is its chemical structure, and to even talk about neurotransmission, I'm going to give you a brief primer. You probably didn't know you were actually going to summer school here, but I'm going to give you a brief primer about how our cells communicate with one another. So this is one cell. You can think of that as a presynaptic cell, and that cell is wanting to talk and communicate with the second cell in order to initiate everything that we do. And so the way that it does that is to release different neurotransmitters, chemicals in the brain. And so those chemicals are synthesized in the cell, they're made in that cell, they're normally stored, and I promise you this will be relevant to my next slide on meth, that's why I'm giving you this primer. They're normally stored in these vesicles where they're released, and then when the cell wants to communicate with other cells, it's it's released out into the cell to act on these receptors to initiate all kinds of actions. And when there's too much dopamine here and we need to get that back into the cell for storage, something called the dopamine transporter pulls that extra dopamine back out of the synapse to pack it back away for later use. And so with dopamine is a very important neurotransmitter in our brain. There's sort of three major pathways that it acts on. One is a cortical pathway. So this is the pathway that we think about as executive function. All of the decision-making processes that we do is there in the cortex, cognition, memory, attention, all of those kinds of behaviors. Dopamine is also very important for a movement pathway. So the initiation of behaviors, the termination of behaviors, dopamine is regulating that. And then finally, there's a third major pathway that dopamine is very important for, and that is our reward and pleasure pathways. So these are the pathways that assign value to things, to different kinds of stimuli. Okay, so why did I tell you about dopamine? So again, here is the chemical structure of dopamine. This is the chemical structure of methamphetamine. So hopefully you appreciate that essentially they're the same thing, right? And what methamphetamine is really good at, better than any other psychostimulant that we know of, is releasing dopamine in the brain. And so this is that synapse I showed you up here that was a normal synapse. This is what happens with methamphetamine. So you probably don't care about all of the details, but basically at each level, at where dopamine is stored in the cell, at where dopamine is taken back up from the cell, it changes all of those cellular functions. So our cells can no longer store dopamine, they can no longer take it back out of the space between two cells, and we just have tons and tons of dopamine out in these cells, in between the two cells, basically overstimulating the system, if you will, when someone is taking methamphetamine. And why does that matter? Well, first, I want to illustrate to you what this looks like. So dopamine is also very important for all kinds of rewarding processes, for, like I said, assigning value to things. So people started looking at, well, what happens in different brain regions to the amount of dopamine when we give a person or an animal a natural reward. So here's our two natural rewards, food and sex. Sex is our most potent natural reward in terms of releasing dopamine. And you can see here, in this case, we have a twofold increase in the amount of dopamine during a sexual experience. Well, put that on the same scale and look at amphetamine. Amphetamine causes a tenfold increase of dopamine in these brain regions that are regulating motivation and reinforcement, decision-making, all places in the brain. This is the amount of dopamine that's releasing. It's absolutely astonishing in terms of the level that it can change our brain. And as a result, we already heard from some folks today about what it felt like to take methamphetamine. In the short term, it causes lots of really good things. There's that euphoria, that rush that you feel, that's dopamine mediated. There's this increased wakefulness, lots of physical activity. There's increased attention, decreased appetite. And then autonomically, there's faster breathing, increased heart rate and blood pressure, and then an increased body temperature. But over the long term, it's really not good to just have all of that dopamine floating around in the cells. And so through a number of different processes, we start to see neurotoxicity. So the cells in the brain start to die as a result of this constant increase in dopamine floating around. And one of the big things that happens is that transporter that I told you about that's able to take dopamine back out of the synapse, it actually starts to go away. There's not as much left. And in fact, the dopamine neurons even start to die. There's also a very strong inflammatory response in the brain. So we've got other cell types that start to go in and think there's been an injury to the different neurons and start to try to clean up that process. And so this just illustrates that. The top panels here, this is an animal study, and the bottom panels is a human imaging study. And so what you can see here, this is the amount of that dopamine transporter that can take dopamine back out of that space between two cells. Red means there's a lot of it there, and as you can see, following methamphetamine treatment, this means there's not a lot, right? It's gone in these animals that were treated with methamphetamine compared to controls. And then here's what people look like. So this is the amount of the dopamine transporter that should be in controls. With methamphetamine, there is a reduction in the amount of that dopamine transporter. And for comparison, this is Parkinson's disease. And so with Parkinson's disease, we have what you're seeing here is an 80 to 90% loss of all of dopamine neurons. So we're not at that point yet with this methamphetamine, but we're certainly not at control levels either. And so as a result of this, what you see are symptoms that are related to addiction and then other kinds of medical symptoms. So over the long term with chronic methamphetamine use, there's the area of the brain, the cortex that regulates decision-making, that becomes hypoactive. And in particular, a certain type of dopamine receptor, the D2 receptor, those become compromised, and we get this what's called hypofrontality. And as a result, we see impaired decision-making, impulsivity, and attention deficits. In addition, that brain region that I showed you that had such a strong increase in dopamine, there's actually structural and metabolic changes that take place in that region. And as a result, that's what sort of underlies the enhanced reinforcement, the greater motivation for methamphetamine compared to anything else, the craving and compulsive behaviors that develop. And then finally, in areas like the hippocampus that are very important for cognition and memory, we see reduced volume in that area. In addition to those sort of addiction-related changes in the brain, there's also a lot of medical risks that increase with chronic methamphetamine use. There's the increased infection risk we've already heard about with HIV, as well as hepatitis. There's periodontal disease, with the teeth. There's chronic high body temperature that happens. And then there's also pulmonary hypertension and cerebral vascular events, as well as stroke. And I think it's important to recognize that with things like stroke, people that have been on methamphetamine aren't as able to recover from things like a stroke. We see kidney failure, and then in addition, we see the development of psychiatric diseases. So they're more vulnerable to developing diseases, particularly Parkinson's disease, which sort of shares that dopamine pathology, and then depression and psychosis. And so I just want to leave you with a little bit of hope at the end of this. And so fortunately, unlike many kinds of diseases, it doesn't appear that some of these profound changes in the brain are permanent. They can actually, when you have been off of meth for a long enough time, start to recover. So again, this is that dopamine transporter that I showed you earlier that can suck the dopamine back out of the synapse. Here's a normal brain. This is a meth user after 1 month being off of methamphetamine, so you can see there's still that very profound loss of that transporter there. But now here's someone that had been on meth that has been off of meth for 24 months, so for 2 years. And you can see it might not be quite the same as controls, but there's a strong rebound of that dopamine transporter. And so again, I think this has important implications for treatments. Something that may not be effective very early on might, over the long term, start to be more efficacious. Okay, thanks.
Thanks, Dr. Ferguson. Next up is Dr. Jonathan Buchholz. He's from the Seattle VA. He's going to talk about the research on medications to treat methamphetamine use disorder and a brief introduction to the major categories of psychosocial interventions. He's the medical director at inpatient psychiatry, taking over for Dr. Andy Saxon, and you're an assistant professor at the University of Washington's Department of Psychiatry and Behavioral Sciences. Dr. Buchholz.
So thank you for having me. Yes, I am taking over for Andy Saxon, and a lot of you know Andy Saxon for about 25 years has been doing the Addiction Psychiatry Fellowship directing role here at the University of Washington, so I have gigantic shoes to fill, and I'm slightly nervous about that. But what I will say, so I am a clinician educator, so I have done all of my training at the University of Washington, and what I primarily do is work with patients, teach residents, medical students, and addiction psychiatry fellows where the rubber meets the road. How do we help these people from a medication standpoint, from a clinical standpoint? And I'm going to talk to you guys today about medication-assisted treatment for methamphetamine use disorder. And when I teach this to medical students, residents, and addiction fellows, most of the time they sort of are on the edge of their seat and are waiting for the silver bullet. And I don't have that. We do not have that, unfortunately. This is a very different substance than opiates. And opioids, thankfully, we have some very good treatments, some medications that work incredibly well, Suboxone and methadone. So this is a different animal. We're going to talk a little bit about what medications are available. I'm not going to get into all of the details of all of the studies, and the reason for that is that you will inevitably fall asleep and it will be bad news bears. So I'm going to talk to you about what we know and what we don't know, and then hopefully leave some more time for discussion. So I don't have any disclosures. And again, we're just going to talk a little bit about medication-assisted treatments. So to start with, from a clinical perspective, how we define substance use disorders, particularly stimulant use disorder, is through the DSM-5. That includes these criteria. Essentially, you're taking a substance in larger amounts over an extended period of time. You try to stop, you can't stop. There's a lot of time spent trying to obtain the substance. You have a lot of craving or desire to use the substance, and you're using recurrently despite efforts to stop, including disruptions in work behavior, school, psychosocial functioning. And then there are these tolerance and withdrawal syndromes that people have. And what I will say is, in medicine, we talk a lot about the tolerance and the withdrawal. We talk a lot about the pharmacology behind this. But as you will see, just in this criteria, and as many of you know who work with patients who are struggling with substance use disorders, particularly methamphetamine in this case, is that the story of addiction is not about the tolerance, the withdrawal, and the brain chemistry. We are going to talk about that, and that's primarily what we're here for. But the story of addiction really is much more how this substance impacts people's lives and what ends up happening from a behavioral standpoint from it. I am not going to go into this primarily because Dr. Ferguson actually covered it, but this is a really cool slide that I'll let you guys access later. This is a genetics model from the University of Utah that kind of explains methamphetamine in a very rudimentary way. It's actually called the mouse model. I use it with patients, I use it with students, and it's a very interactive way to know what's going on in the brain. This is a slide that, again, Dr. Ferguson has already discussed, but I always tell students and show these slides because people often ask me, so this is causing people's teeth to fall out, their skin to be picking, they're becoming psychotic. Why the hell would you use this, right? And I think all of us here can understand this notion of if an orgasm is about where this is in sex and a 10 times more potent response is using methamphetamine, like, you let that sink in for a second. This is an incredibly powerful substance. And to deny that or to try to not understand that is missing the boat here. This is an incredibly potent substance that is incredibly rewarding. So the Veterans Administration published an evidence-based synthesis essentially looking at all of the studies that have been done to date on methamphetamine, and published this in August of 2018. Dr. Saxon and colleagues from the university and the Center of Excellence over at the VA contributed to this. And so this just took a look at what is the evidence, what do we have, and I'm going to summarize from that and from other systematic reviews kind of what do we know. So what do we know? And what we do know is it's really hard to study, actually. There are only 14 really good randomized controlled trials and one systematic review that has looked at patients with particularly methamphetamine use disorder and using randomized control data to drive what we know about this. And that compared to other things like opiates, which have hundreds of studies, this is limited. And so that's one of our problems. One of the other problems is coming up with an overarching treatment approach from a medication standpoint. We have to be able to compile studies and use them together. And one of the problems is that a lot of these studies are small and they use different outcome measures. They're underpowered to actually give good data. And so what I'm going to tell you sounds a little bit demoralizing, and that is that we don't have a great medication right now. That doesn't necessarily mean there isn't some treatment that can really help. So we'll talk about that. So what do we know as far as medications that are inconsistent or don't have great, robust data? There's a lot of them that have been tried that really don't have great data. I will say a caveat about naltrexone and bupropion. So naltrexone is used in the treatment of alcohol use disorders and opiate use disorders. It hasn't had great data. With that said, it has been tried in patients who have co-occurring opiate use disorder and methamphetamine use disorder, and some promise. So there are more trials that show that it doesn't work than it does, but there is some promise. So we're going to talk mostly about mirtazapine, PureMate, and methylphenidate in terms of treatments. So to PureMate, there's essentially no systematic reviews. There's one really good randomized controlled trial of 140 participants. What it showed was that folks who were in the topiramate group, and topiramate is this medication which works on GABA receptors, which essentially means it is a substance that helps people sort of calm down, right? So these are the same receptors that alcohol works on, that benzodiazepines work on. And what it showed was that it reduced relapse rates in those who are already abstinent. It did not improve abstinent rates overall, but it did reduce the amount of methamphetamine taken in this study. And it was a 12-week study, which is limited, 140 participants, which is also limited, but this has some promise. Mirtazapine. So this is another study that is a subpopulation study. This is folks who are men who have sex with men. There were 60 participants, and they found that folks who were taking mirtazapine, again, mirtazapine is a medication that's an antidepressant. It works a little bit differently than some of the other antidepressants, but it helps with folks who have difficulty sleeping. It helps with folks who have a lower appetite, and it is an anxiolytic medication that is in the antidepressant category. What they found in this population is that those who were taking mirtazapine had more negative urines in the study. And then the number needed to treat to find abstinence from methamphetamine was 3.1. So that's actually a very good number when you look at methamphetamine studies in totality and even with other medications. The unfortunate part about this is that there wasn't actually improvements in treatment retention, which many of you know, working with patients with substance use disorders, particularly methamphetamine, engagement in treatment and keeping them engaged in treatment is really paramount. So I'm going to talk about methylphenidate. Again, I'm going to talk about this briefly because I want people to be able to ask questions. I know that you have a lot of questions about stimulants. So methylphenidate is a stimulant. It's a stimulant that we use for things like attention deficit disorder. There are some randomized controlled trials, and in combining these, what we found is that 3 out of the 4 studies showed a reduction in methamphetamine use while people were taking methylphenidate. And so this was using methylphenidate to try to reduce people's use of methamphetamine, similar to using Suboxone or using methadone as a replacement strategy. Unfortunately, because of the pharmacology behind opiates and methamphetamine being so different, methamphetamine just doesn't do the same thing when it comes to replacement. We want it to. It would be lovely if it did, but it doesn't have the same robust outcomes. Again, though, that doesn't mean that there isn't hope for the future. There were no differences in treatment retention when looking at the studies of folks using these medications. But there were a bunch of limitations, and I think this is where the hope is in this body of evidence. There were low doses of methylphenidate used. One of the biggest problems is, when I treat somebody with an opiate use disorder and start them on Suboxone, I'm using a medication that I can get someone stabilized in a week, right? Using very similar types of levels of substance. When someone's injecting methamphetamine and I use this methylphenidate at a very low dose, it's apples and oranges. We're not actually doing the same amount of replacement. And so some of these studies, what they are actually trying to do moving forward is showing, let's see if we can increase the dose of some of these medications, and maybe that would be helpful. The other part is actually looking at subpopulations, because there are populations that tend to do better with stimulant replacement. And one of those populations is attention deficit disorder. So Fran Levin and colleagues have done most of the research in this area and have shown that folks who have attention deficit disorder, who are using methylphenidate, do engage in treatment a little bit better and do have some better outcomes. Again, that is limited by the fact that they were using lower doses of these medications. One of the myths that I want to dispel and I think runs pretty rampant is that if a person has attention deficit disorder, my kid has ADD, and I go to the doctor and put them on a stimulant medication, that's going to mean that in the future they're going to be addicted to amphetamines, and they're going to be at higher risk for amphetamine use disorder or methamphetamine use. And that is not the case. It's actually just the opposite. If you treat attention deficit disorder, there are lower rates of substance use disorders overall, including methamphetamine. So when I tackle this from a medication side of things, I try also as much as possible to identify co-occurring disorders and treat those co-occurring disorders. Things like psychosis, depression, anxiety, ADHD, these are very common amongst folks who are using methamphetamine. And those are actually primary disorders. They're not secondary to the substance, but primary disorders that are underlying those things. All right, so I'm going to stop for now, and then we can go ahead and take some questions.
So we'll start with questions from the audience. Anybody have questions? If you don't, I do. Please.
My name is Allison Branthank. I'm the health officer for Clallam County. I also lead an MAT program out there. And one of the common issues we run into is sorting out ADD versus just the things that you would normally see when someone's on meth. Do you have any recommendations clinically for how to do that?
Yes, that's incredibly difficult to do. So one thing that I do is I try as much as possible to establish a diagnosis of ADHD in childhood. So get the history from the patient. If they can't actually tell you the history, try to get a collateral resource, a mom, a brother, something from their past. I will tell you also that if there is a patient who's showing symptoms of ADHD but had no history of ADHD beforehand, it's incredibly hard because methamphetamine hijacks the dopaminergic system and actually can mimic ADHD if you overuse methamphetamine. Just as Dr. Ferguson was saying, it can actually cause attentional problems if you overuse it. Whereas when people tell you, I use that so I can focus, well, in the beginning, yeah. But when you use it over and over and over and over again, it destroys those dopamine receptors and people have a very difficult time.
Hi, I have a question. My name is Jesse Rollins. I'm with the Public Defender Association. And with the methylphenidate studies, was there an inclusion of other types of services with the methylphenidate, like contingency management, or housing or other services in those studies?
Yeah. So I didn't introduce the psychosocial part of this, and mostly because there's going to be some people talking about the psychosocial services coming up after me and Dr. Ferguson. Yes, all of these studies have some form of behavioral component to it. Weekly psychotherapy, contingency management. But the problem is that they're not universal. So some studies use CBT, some studies use contingency management, some studies have people coming right out of incarceration. So we're not, that's one of the challenges is we're not comparing similar studies because they are all a bit different in their design.
So, sorry, just a follow-up question. What would you suggest for a future study?
So what I think is important is for us to recognize that this is not a magic bullet kind of situation. Suboxone for opiates is wonderful, and it works for a lot of people in a lot of different settings. That's not the case with methamphetamine. Even people taking methylphenidate in the most controlled contingency management way are not the same. What I would say, just in my opinion and having reviewed this literature in the last year, is that contingency management probably has the most evidence so far. And again, we'll let the folks with the behavioral component talk about that specifically, but I'd like to see more studies that combine some medication-assisted treatment in contingency management approaches.
Okay, thank you.
So I'm going to ask a question. Dr. Ferguson's slide talked about the fact that folks will have a toxic psychosis if they do too much high-grade speed. So you're a psychiatrist and somebody comes in and they have delusions, they have hallucinations. How do you know, and they also endorse methamphetamine use, how do you know which is organic and which is toxic, and when do you decide to medicate that person?
So that's a great question. And what I tell residents and medical students, again, getting one slice in history is incredibly hard. Somebody walks into the door and is having, delusional parasitosis. That could be schizophrenia. It could be methamphetamine. And what we find mostly is that folks who are using methamphetamine who have psychosis don't necessarily have some of the same negative symptoms that folks with schizophrenia do, meaning their life history looks different. Folks with schizophrenia tend to have more negative symptoms, meaning social interactions are not as robust. Their affect is not as ranged. They tend to isolate a little bit more. Their baseline level of functioning is generally a little bit lower. So with folks who have methamphetamine-induced psychosis, there's just more positive symptoms than there are negative symptoms. And those psychotic symptoms tend to go away a little bit quicker. Again, that's also not universal, because there are some interesting research findings that people can have persistent psychosis for longer periods of time, and in those situations, it's very difficult. But again, what I would also advocate is that there is a neuroplasticity. The brain does heal. It just takes a hell of a long time, and we have to have the patience as clinicians and as people taking care of folks who have methamphetamine use disorder to know that this has hijacked their brain, and it may take 18 months or 2 years before that person's back. I saw an individual literally yesterday in the hallway at the VA who I'd taken care of 3 years ago. He was incredibly psychotic and was in the hospital for more than a month. He didn't recognize me in the hallway, and I was like, oh my God, you look great. And he was clean and sober for the last 12 months. He had no recollection of me. He was psychotic in the hospital the 2 years prior, only because of methamphetamine.
So to follow up, when do you decide to start the antipsychotic medication on the person who's exhibiting those psychotic symptoms?
So unfortunately, antipsychotics are not great treatments for methamphetamine-induced psychosis. We try as much as we can to help people in the acute setting, even if it's regardless of what the psychosis is. We will try at times antipsychotic medications. The downside to that is that it does actually disrupt dopamine in some of those same areas that methamphetamine has already caused problems with, like cognition. And so we may help someone's psychotic symptoms, but then they find they're very dulled and they don't like the way it makes them feel. And so it's a challenge. It's a challenge. And so that's where, again, there's not a magic bullet, and you have to take people where they're at and really try to understand the individual and what they're struggling with, to really create a detailed approach to the person, and not necessarily like olanzapine or risperidone or an antipsychotic is sort of the way to go.
Thanks, Dr. Parker.
And I just wanted to mention something. You were sort of talking about the neuroplasticity in the brain, and I think it's important to kind of keep in mind a lot of the neurotoxic effects that we were sort of touching on these transporters and the way that the dopamine system works as a functioning system. Those things start to recover, but there's also a different kind of plasticity that's taking place in those neurons that we think may be permanent. And what that plasticity is doing is rewiring the brain. I mean, our brains sort of evolved to tell us what's good, what's bad, what kinds of things we should like in the environment, what kinds of things we want in the environment. And all drugs, but particularly psychostimulants and particularly methamphetamine, is rewiring those neurons in the brain to lead to essentially permanent adaptations that underlie things like craving. And so, in fact, even though a lot of maybe the psychosis and the cognitive effects and a lot of those kinds of effects may resolve over time, craving can actually get bigger over time. And so that's why someone that seemingly is functional, you're like, wow, you know, this person has their life back together, they've got the job, they've got the family, and they can see some sort of stimuli that was associated with the drug use, or really it's, you know, you may have more experience with obsessive compulsive disorder. People with obsessive compulsive disorder, it's very similar. They start to talk about how it sort of bubbles up, the kind of, you know, wherever their focus is, their preoccupation, it just gets bigger and bigger and bigger over time, and then they have to relieve themselves by doing whatever they were obsessing about or having a compulsion. And drug addiction can be very similar. That craving gets bigger and bigger and bigger, and it doesn't go away until there's relapse.
One of the more persistent elements of post-methamphetamine recovery is aphoria or anhedonia, which means the brain has lost its ability or has diminished ability to pleasure itself. So what advice do you give to people who are in early recovery about how they overcome that period when they can't get off just on nature or a nice dinner or sex with their partner or whatever?
Yeah, that's a hard one. I mean, I'm just going to be honest. That's a hard one. I mean, people will tell me that and express that to me, and I try as much as possible to talk to them about cognitively recognizing that this is what is happening in their brain, and trying as much as possible to help them find whatever it is that is pleasurable to them, and encourage them to do the best they can. But I don't have a great answer for that. That is a huge problem.
Thanks. Please.
So I'm just curious, in the long term, do they...
Please use the mic.
Sorry. In the long term, do the CT scans change? Do they have brain volume loss if there's chronic substance use? And since there's the similarity to Parkinson's, has there been any trial of levodopa when off? I'm just curious.
Yeah, there had been an L-DOPA trial in the 90s and the 80s, and interestingly enough, unfortunately at the time, successful outcome was considered 100% abstinence. And now we've really changed our thinking with harm reduction, and even if you decrease methamphetamine use, that would be a success, right? And so I think people are starting to go back to L-DOPA. My understanding with L-DOPA is doctors don't really like prescribing it. It can have lots of bad side effects and that sort of thing. But the other problem is if you're getting the dopamine loss, even with Parkinson's, eventually it's not effective anymore. And so that could be a similar kind of thing with methamphetamine. You would sort of depend on what stage you were at. But again, maybe low dose therapy in combination with something else might be effective. Yeah.
Brad?
If the brain kicks in after 2 years, or then you would think that you could start with the levodopa, and I've been a neuronurse too long. Sorry.
Yeah.
And it's like,
Yeah, and one of the problems is that even L-Dopa or at the highest doses is not the same as methamphetamine, and so it's actually more sort of targeted in the areas of the brain that are responsible for movement, as opposed to these areas that are talking about reward and concentration and things like that. And so those are the deficits that we actually see more readily in behavioral management and in mental health. And so L-Dopa just doesn't do as well in those.
Yeah, and as was mentioned, we really don't have very good replacement medications, right? They're not working. So one of the things they are working very hard on preclinically is the idea of a vaccination. And so it's sort of an immunotherapy with methamphetamine, where basically your body would make antibodies to it. Those antibodies, when someone would take methamphetamine, would bind to it and basically sequester it away. It wouldn't go into the brain. And the idea there is if you're taking something that's not having an effect on the brain, why would you keep taking it? And so while it's not a treatment per se, and I'm not sure, they're not even at the stage of clinical trials at this point, but that's, in terms of medications, maybe what's on the horizon.
Yeah, well, NIDA's been working on a tobacco vaccination for about 40 years, so stand by that.
So the other thing on that is that there is a drug for cocaine that is the vaccination, and it was working wonderfully well in rats, and then the human trials have literally just come out and it's not working as well in human beings, and so we're complex creatures.
Brad?
So, Dr. Ferguson, I just want to know how you feel about becoming Caleb's boss. No, I'm just joking. I'm just joking.
Very excited.
Please don't. No, I'm just joking. So, one of my questions is about sort of the changing field of SUD treatment, and that it's harder to get people into detox and withdrawal management for methamphetamine use because the manifestation of symptomology is different, and we've heard a number of times today maybe one of the best treatments is time and abstinence and recovery, and residential stays are getting shorter and shorter in the treatment field, and I just wanted to get your take on both of those.
Yeah, so there was a talk about Ricky's Law earlier, and I'm a clinician, and I interface with Ricky's Law, and the notion that it can somehow help us, I think is, how do I use a term that's not going to offend anybody? It doesn't work. So patients who come in for 72 hours for treatment of methamphetamine use disorder, that's a joke.
Say that again, please.
It's a joke. I want to try to help people as much as I can, and if it means a couple days in the hospital against their will, like I would do that if it worked, but I have seen it and it doesn't. So I can't speak about that just from my own clinical experience, but again, the more time away from methamphetamine in whatever means can have that happen, the better.
Last question over here.
My name is Valerie Robertson. I work for the Pierce County Health Department. I'm a dispensing nurse, and I also work at Tacoma Detox. And you said that you were introducing methylphenidate.
Yeah, methylphenidate. Yep.
Is that the same thing as Ritalin?
Yeah, so there are a lot of different versions of stimulants, and I won't get into all the details of that, but the Ritalin, Adderall, methylphenidate, there are a lot of different medications, but in the same class, which is a stimulant class.
Right.
Yeah.
Does the DEA support that diagnosis for methamphetamine withdrawal management?
No.
Or does it has to be ADHD?
It has to be ADHD.
Okay.
If we're treating patients with methamphetamine use disorder with methylphenidate, we're doing it off-label and it is not
Right.
approved by the FDA.
Right. And what I also find when working at Tacoma Detox is you're right, they're only there for 3 days. And then we just release them to nothing, sometimes not even inpatient treatment. And my heart breaks because then we're just releasing them to continue what they've been doing. So if we can get other clinicians and other addiction specialists to get on board with introducing stimulants to help with methamphetamine use, that'd be wonderful. But I don't know if a lot of clinicians and addiction medicine specialists know about it.
Well, and there's a lot of hesitation too. So
You're right. You're right.
physicians do not like prescribing stimulants, particularly to
absolutely
people who
right.
have stimulant problems.
Absolutely right.
So I want to say thank you to Dr. Ferguson and Dr. Buchholz. Thank you.